Alrighty, so term one, pathophysiology, week one. I'm going to go over two different sections of slides here. Come on, there we go. Make sure you're a good student. Go through your Sakai stuff, make sure it's all good. Objectives, yada, yada, yada. All right, so this is going to be a pretty brief slide section here. So pathophysiology is just the study of the body function in disease and the altered health. Look at all that stuff. So a few words that are important to remember here. Etiology, this is going to be, okay, so we have etiology, pathogenesis, clinical manifestations, and treatment. They're all important for learning pathophysiology. Etiology is going to be that basically the cause of the disease. Like what brought about the disease. So someone being exposed to anthrax and now they're diseased. The anthrax was the etiology. The exposure to the anthrax was the etiology. For pathogenesis, this is going to be the development of the disease, how the disease goes from exposure to full-blown manifestations of symptoms, and from then through to whatever the end point would be of the disease, or if the disease is incurable, then how it progresses throughout the person's life. Clinical manifestations, fancy way of saying symptoms. This is an important definition here of what health actually is. It is not merely the absence of disease or infirmity. It is the complete physical, mental, and social well-being. And so there are going to be, of course, multiple influencing factors on what can make someone healthy or can inhibit someone from being fully healthy. A disease or a pathology is going to be a deviation or interruption of normal structure or function. It could be manifested by signs and symptoms, and is described by the etiology, pathogenesis, clinical manifestations, symptoms, diagnosis, and the clinical course. All right, so when it comes to determining clinical manifestations and a diagnosis, there are going to be times where we have to do plenty of tests. That's what a lot of our jobs are. So when it comes to figuring out the quality of some of these tests, this is not very, very important right now for Path and Pharm. It is more important for epidemiology. But some of the things that we have to be considerate about for tests are going to be the validity of those tests, which is going to be the accuracy. So does the test measure what we want it to measure? And then reliability. Are we able then to use the results of that test and have the same outcomes, the same results every time we do the test, making it reliable, making it so that we can have repeatability of that test. Predictive value, this is normally expressed as a positive predictive value or a negative predictive value. It's very similar to sensitivity and specificity. Don't need to really go into much on this. Just remember that sensitivity and specificity generally is about, from the perspective of public health, sensitivity is going to be how well does a test identify diseased patients. So if you were going to throw out a screening test for a massive population, how well would that test identify those who have a disease? Specificity is going to be the inverse of that. For screening a whole bunch of patients, how well is that test going to work in identifying those who are not diseased? Being good at one, having a test that's strong with sensitivity does not mean it is good for specificity. Nor does being good at one mean you're bad at the other. There's a bunch of complicated factors that work together to determine mathematically whether you are good at, whether the test is highly sensitive or highly specific or both. It's complicated. Positive predictive value and negative predictive value. Predictive value is going to be more pertinent from the perspective of the clinical site. So when you're in there, you're actually working with patients. You give a patient a biopsy, for example. That biopsy comes back as being positive. The next question will be is what is the positive predictive value of that positive result? Meaning, how likely is that person who got that patient who got that positive result, how likely is it that they actually have the disease? And the inverse is going to be the negative predictive value. If they definitely did not, if they got a negative screening on something, a negative test, does that, how well does that mean that they definitely don't have that disease? They see the predictive value and sensitivity and specificity are very similar feeling. There are times where it gets really complicated and you're like, what in the heck are the differences? This is just a brief overview of it just to get you familiar. You'll find out more about it with epidemiology. And one important thing to remember is that predictive values are tied into how prevalent a disease is in a certain population. If you are doing a test on a group of people who have, and you're testing for a disease that is very, very, very rare, then you're looking at a very good chance of having very low predictive values on a specific test. But if you pinpoint a very specific high-risk population, then the predictive values of that test for that disease are going to go up much higher. That's all. Disease classification. So congenital is going to be that you are born with it. Idio or iatrogenic is going to be that it's caused by medical treatment. You never want to do this, but sometimes it happens. Idiopathic means we have no idea where it came from. Immunologic means it has something to do with the immune system. Maybe there is a hyperactive or hypoactive system, and so that's what's causing a problem. Eczema, for example, is one of those. It can be inherited, which is different than congenital. Inherited is that it is genetic. Congenital means that it is something that started with birth. Nutritional deficiencies can come from either being hypo or hyper fed. Having too much can lead to, if you have too much sugar, that could be a risk factor towards type 2 diabetes. Having too little, you don't have enough protein in your body. Is that Kawasaki syndrome? I can't remember. And then we can have psychogenic classifications for disease, so that there is some sort of a psychological or manifestation or origin. So for example, let's say anxiety could be possibly one of those, or I think like schizophrenia falls under that. I think it might actually have a couple of these put together. Good one. Prevention and treatment. By understanding what etiology is, pathogenesis, clinical consequences of a disease, blah, blah, we can go about figuring out better how to prevent it, how to treat it, etc. Oh, that's it. So now we're moving on to the next set of slides. Cell adaptation, injury, and death. All right, so homeostasis is going to be the balancing act that our body does of the different physiologic processes that are going on in our body within the immediate setting. So for example, you're lying down on the couch, you're all nice and comfy, you're nice and warm probably, and then you decide, oh, I gotta go to the bathroom. You jump right up, you start racing to the bathroom, all of a sudden, wow, you're seeing stars, holy crap. You just had experienced orthostatic hypotension, because your heart was not quite ready for that sudden change in body positioning. But what your body does to maintain homeostasis is it ramps up your heart rate. It causes some vasoconstriction of the peripheral blood vessels. And it gets your blood volume, or not blood volume, it gets your blood pressure back up to a working normal. And that's why you don't pass out, hit your head, and die. You start seeing the stars, but then you bend over for a second, give yourself maybe 10 seconds, and you're like, whoa, okay, now I can go to the bathroom. And you're off to whatever you gotta do for the rest of the day. That's homeostasis. Allostasis is a long-term balancing act. So this is going to be basically the response that the body develops over time to maintain homeostasis based on what the elements are in your external environment. So, for example, if a person was, that person who just you got up, went to the bathroom, all that stuff, you're living in a peaceful environment in your house and all that, and then suddenly it's World War III, everything around you is in chaos, you are having to fight for your life, etc. Your normal blood pressure of 120/80 might be enough to sustain or to maximize your chances of survival during that conflict. And so your body's going to recognize that from the excess of cortisol, epinephrine, norepinephrine, and you're going to have your body is basically going to change the set point in the hypothalamus. I think it's the hypothalamus. Is going to change the set point for what your blood pressure normally is to meet the demands of your external environment. So instead of 120/80, we're going to bump it up to maybe 130/90 or 140/90, just to try to meet the demands of your external environment. That's allostasis. Sometimes allostasis can be a good thing. Sometimes allostasis can be a very detrimental thing. So, for example, if you have a tremendous amount of sugar all the time, your body is going to, at first, give a whole tremendous amount of insulin to meet that sugar, and it's going to shuttle right into all your cells. Over time, your cells will become less sensitive because they're recognizing, oh, holy crap, look at this. We have all of this extra sugar. We don't know what to do with it. We're not going to accept it as much. And so now your cells become less sensitive. They become insulin resistant because of the excess exposure, which is bad. That's not a good thing. Okay. Blah, blah, blah. Okay, so I'm pretty sure we all know pretty well the cell membrane. Cell communication. So there are three main ways in which cells communicate. We've got gap junctions, which will directly connect the cytoplasm of adjoining cells. This is going to be really important for things like cardiac muscle contraction. So like what we can see up here, these little guys, these little doohickeys here are going to be the gap junctions that connect. I think this is a neuron. I don't know. I think that's what this says, parasympathetic something. There may be some conflict of information here. But anyway, so gap junctions are going to be connecting the cytoplasms of adjoining cells. So we have the cytoplasm of one here, cytoplasm of another here. I think I really want to say these are what these are. Well, okay, gap junction right there. And so they're exchanging stuff between the cytoplasms of two adjoining or two neighboring cells. Direct cell-to-cell contact involves connection of the plasma membranes rather than the cytoplasm. So with the plasma membrane, that's like this guy right here. So I don't know whether that actually is correct. Anyway, so this is, for example, an APC, an antigen-presenting cell, connecting with a protein on a T lymphocyte, this guy here, and saying, hey, I found this little bad guy over here. I don't know what you want to do with it, but I figured I'd show it to you. So that's what that direct cell-to-cell signaling would be. And it's because of the proteins found on the plasma membrane of each of the cells. The most important one for this course is going to be the secretion of chemical mediators that influence other cells, also known as cell signaling. And there are going to be three different types of cell signaling in that regard. So we have endocrine signaling. This is going to be just the endocrine system and relies on the flow of the circulatory system to transport the signaling material from one cell to another. And for example, this would be the pituitary signaling the thyroid with thyroid stimulating hormone, with the attempt being to try to get the thyroid to release T3 and T4. So the next would be paracrine signaling. This would be signaling of nearby cells and does not rely on the circulatory system. So they're going to be traveling through perhaps the matrix, not the fancy matrix, the intercellular matrix, and the interstitial fluid, anything like that. And this is going to be used for things like coagulation, allergic response, tissue repair. Those are all examples of paracrine signaling. Autocrine signaling, as you can imagine from the prefix auto, means that we are self-signaling, or that cell is self-signaling. An example of this would be a T lymphocyte detects an antigen producing a growth hormone that it responds to, and leading then to the creation of more T lymphocytes. Okay, so cell injuries come in a spectrum, all the way from if it's a mild and short-lived injury, then the cell can withstand the assault and return to normal. Good, wonderful. If it's, that would be, for example, a cut. You get a cut. Some of those cells will die. More than likely, most of them will, I'm not sure that's actually the best. Let's say a little inflammation. That's that cut caused on the perimeter of the cut some inflammation. Inflammation is not good for cells. They start to get red, absorb a lot of fluid, etc. But it's short-lived. It's then good for the healing process of all the rest of it, and everyone recovers and is happy. If it's a persistent but sublethal form of cell injury, then that cell will adapt by changing the structure or the function of itself to basically withstand the whatever it is causing that injury. So let's say a person has GERD. They are on a regular basis having gastric acid, gastric contents going up a little bit into their esophagus through that sphincter and causing repeated but not quite lethal levels of injury and inflammation to those cells. Those cells will then change to what's called, I think, Barrett's esophagus, which is a potential cancer risk, and suddenly now we have a difference in structure. If it's a severe or prolonged or irreversible injury, then the cells will die. So like gangrene or frostbite, the cells are not going to withstand that and they're going to die. Some of the specific types of cell injuries are going to include hypoxia or hypoxic injury, which is going to be inadequate oxygen. All cells require oxygen for the purpose of cellular respiration, aerobic metabolism, and if they don't have enough oxygen, they will die. This is going to be the most common cause of cell injury, and is most often caused by ischemia, which is going to be inadequate perfusion. So all of our oxygen travels via blood. If we don't have enough blood flow to a certain region of the body, let's say a person has a heart attack where there's a clot blocking part of the vessels that serve the heart. Now suddenly the heart is missing important critical oxygen and blood flow, and those cells are then going to go through apoptosis or necrosis, probably necrosis, given that this is a unplanned death. We can have also nutritional injuries from either overeating or undereating. We already covered that a little bit. Infectious etiologies or injuries can come from bacteria, viruses, fungi. We all kind of know how those work. We can have immunologic issues, as mentioned earlier, like allergic responses and autoimmune issues. We can have chemical injuries. So, for example, we can have things from within, such as hyperglycemia. It kind of comes from something externally, but we have a whole bunch of extra sugar. That extra sugar can be corrosive, can create a really nasty effect on the arteries. We can have the exposure to toxins or carbon monoxide poisoning from sitting in your car for too long, in a garage, and now suddenly all that extra gas and carbon monoxide builds up in the garage and you have poisoning. Physical injuries include things like mechanical injuries, which is down here, thermal, so sitting in the sun too long, getting a sunburn. Radiation, similar, works together with thermal. Inflammation is a form of physical injury. And then mechanical injury is going to be things of like a physical nature, such as getting hit by a car. Free radicals are also mentioned specifically as being a form of cell injury. And the way that free radicals are a problem is that they have one electron in their outer shell, and that makes them really unstable, really reactive, and so they're going to do whatever they can, whatever they want, with whatever environment they're put in. They can penetrate and react with a cell's membrane, as well as the organelles inside of that, and cause what we all hear about all the time as oxidative stress. We naturally will make free radicals, and that's a byproduct of cellular metabolism. We make those little oxygen molecules as part of creating ATP, but we normally use enzymes to help to neutralize them. So, and the damage is especially concerning with the impact to DNA, since that's a risk factor for leading to cancer. An example of free radicals in the body would be, unnaturally, a Tylenol overdose. So that's going to result in a massive free radical release, which then causes long-term liver damage. All right, so hydropic swelling or hydropic swelling. If you're using the same book that we used, this will not be in the book. This is in the book that was for the class 1 year previous to us. I guess it'd be helpful to say what that is. Class of 2019. So it was class of 2018's book that was used for this. I happen to have gotten a copy of that. So hydropic swelling, all of these cells are going to have sodium-potassium pumps that work great at maintaining the electrolyte balance between the inside of the cell and the outside of the cell. When there is any kind of an injury, or I guess injury is the right word, that interferes with the number of ATP that are created, then the pumps, the sodium-potassium pumps that rely on that ATP are going to stop working, because sodium-potassium pumps require the ATP for energy. When they stop working, there's going to be an excess amount of sodium that comes into the cells, because the sodium-potassium pumps are trying to create that gradient of having a lot more potassium inside the cell and a lot more sodium outside the cell, which helps draw that liquid, that water gradient as well. But if that sodium-potassium pump isn't working, then we're going to get a whole bunch of extra sodium inside the cell, leading then, of course, to extra water following that sodium, and we get this hydropic swelling. No, this is normal, I think. This is hydropic swelling. Some of the cells begin to burst. Not good. I don't think that we ever covered this after this slide, so I can't say for sure how important that is. But I found that in the book, the older book. We can also have intracellular accumulations. So these are going to be either excessive amounts of normal substances, abnormal substances that accumulate due to faulty cell function, or pigments and particles that accumulate and the cell is unable to degrade them. So excessive amounts of normal substances, when we have excessive ETOH or alcohol, that's not the substance they're referring to, hepatocytes are going to have, they normally have some level of fat accumulation inside. But when exposed to excessive ETOH, they get extra fat brought into their system or into the cells, and it becomes a fatty liver, which can then lead to cirrhosis. We can have abnormal substances that accumulate due to faulty cell function, such as if there is a lack of an intracellular enzyme, then this can result in the accumulation of a substrate that the enzyme was meant to act on. So I don't know what we could use exactly as an example here, but there's a substrate, a chemical of some kind that comes into the cell naturally, and it's meant to, once it comes into the cell, is meant to be broken down, acted upon by an enzyme, and created into two different types of materials. But for whatever reason, there is a lack of that enzyme inside the cell that is supposed to be there, and now we have these abnormal substances building up inside the cell that shouldn't be there. For pigments and particles, we can have endogenous particles or pigments that build up. So for example, we can have excess bilirubin due to hepatobiliary disorders resulting in jaundice. So a lot of those cells are going to accumulate that bilirubin, making everyone or everything look yellow. We can also have exogenous particles or pigments, such as contrast media for doing MRIs with contrast, or perhaps doing working in the mines and getting mineral dust in the lungs, and the cells in the lungs picking up and accumulating that dust. So cells are going to change based on the internal environment and increased demands. They can change in size by atrophying and hypertrophying. They can change in number by hyperplasia. They can go through hyperplasia, or they can change in form, such as metaplasia and dysplasia. So these are going to be our normal cells. Atrophying is going to be where they are decreasing in size. The same number of cells, but they decrease in size. Hypertrophy is going to be the opposite. Same number of cells, but they've gotten bigger. Hyperplasia is different than hypertrophy. Hyperplasia is going to be they're increasing in the cell numbers. So they're the same size as the normal ones, but now they're all bigger. Oh, I'm sorry, the same size, but now there's just more of them. Metaplasia is going to be the conversion of one cell type to another. So, for example, that Barrett's esophagus, having GERD and having all of that gastric contents coming up from the stomach to the esophagus, leading the cells in the esophagus to change as allostasis to a different type of cell to meet that demand. So we have our normal cell, a couple of normal cells here, normal cell here, but these guys have changed because of whatever that environment is exposing them to. Dysplasia is going to be disorderly growth and is a risk factor towards neoplasias, which are cancer. So as you can see here, we have our two normal guys here, and then we have a whole bunch of just funky looking, disorganized, no real sense to their structure cells. Let's see, so with our, I think this is easier to see. So we got atrophy, a paralyzed limb would express that, would show that. Hypertrophy, we can have positive hypertrophy from working out and developing better muscles that help to do the work you need them to do. Pathologic hypertrophy could be left ventricular hypertrophy. So the left ventricle is going to get thickened and larger due to hypertension. And you'll get into that more in a bit. Hyperplasia. So we have an increased number of cells, right? They're the same size as our normal ones, but now there's more of them. This would be an example of prostate enlargement from excessive testosterone, especially as men get older. We also have metaplasia, which is right here, the example being GERD, as mentioned before, all that gastric contents to the esophagus. And then dysplasia would be, for example, cervical cancer. And then there's also neoplasia, which is going to be new growth with disorganized, uncoordinated, and uncontrolled proliferation of cell growth that is cancerous. Not all dysplasia is cancerous. Neoplasia, I don't think is always cancerous, always. I think it's... Now I'm doubting myself. Dysplasia is definitely not always cancer. There are going to be times where you're going to see it, and it's simply disorganized growth. It's a cancer risk. Neoplasia is a form of cancer or tumor. We'll keep it there. Okay, activity stuff. All right, so when we get to irreversible cell injuries, we have two options for how those cells will die. Apoptosis is going to be the normal form of cell death, and it's programmed. So this is going to be all cells naturally have this time frame where the body's like, hey, you're out of you've gotten there, good job, time to go. Because otherwise we would just fall apart after a number of years. So you go through condensation, fragmentation, apoptic bodies, and everything kind of cleans them out, and it's like it never existed. Bad death is going to be necrosis. This is unplanned. This is due to an internal or external factor that was not in planning, and can lead to other forms of cell death as well. So cells also age. They can accumulate metabolic damage. They can accumulate DNA damage over time, which is natural. So for example, like telomeres are partially what help to control and give these cells their ability to replicate, reproduce. And over time, they shrink, making it much more difficult for them to properly reproduce. And that leads then to the potential of developing cancer. Cells also can decrease their proliferative capacity, or there's a decreased proliferative capacity of stem cells, which are like our backup cells. Sometimes they are the primary cells that then differentiate. And if there are no stem cells, or if they can't differentiate the way they're supposed to, we've lost a lot of our ability then to replace cells that die. So when we have somatic death, just actual full body death, it's the death of the entire organism. There are no respirations, no heartbeat. There are a number of things that can or that will present themselves, and you can kind of judge how far gone a body has been, how old it is, based on the presentation of some of these factors. And a few of these kind of happen at once. So for example, pallor mortis, or no, that's not that one. So pallor mortis is going to be paleness from loss of perfusion through the capillaries. When that heart's done beating, we're not going to be continuing to get blood flow going through anywhere because the heart's the pump. It's dead, it's dead. And that begins as soon as someone is fully dead. Algor mortis is going to be where the temperature decreases to the ambient temperature of the air around them, which is the same thing as poikilothermia. Those two things, pallor mortis and algor mortis, happen the moment death occurs. Rigor mortis is going to occur, I think it's within an hour or two. That's not important to know. And this is where they become rigorous. They become not rigorous. They become. I always think of rigor as being very stiff. Rigor mortis is that the limbs become stiff. So you try lifting someone up, and they're not going to be able to bend their arm if you try to bend their arm. And then we have livor mortis, which is going to be dependent lividity. So dependent lividity is where we have blood settling. So when we have the pump no longer working, cells are no longer working, then we're going to have blood leaching out of the blood vessels and kind of settling into whatever lowest points they possibly can. So if we have someone lying on their back, that's going to be their backside touching the ground. The weight of their body on like their shoulder blades, their sacrum, their heels is going to prevent the blood from really reaching those pressured areas, but it's going to basically create like an outline around where the body was touching the ground, if that makes sense. And then post-mortem autolysis is going to be putrefaction of the body. So literally everything is broken down. It's done by enzymes. Mother Nature and her little insects tend to help out a lot. Pretty much the grossest part of the decomposition of the body. Okay, so little comparison here between apoptosis and necrosis. Apoptosis is programmed. Necrosis comes about from stressors or injuries. With apoptosis, the cell is going to shrink naturally and fragment off. With necrosis, there's inflammation more than likely. The cell is going to swell. With apoptosis, the chromatin is going to condense. The membranes for necrosis are going to start to disintegrate. There is little nice budding and orderly fragmentation with apoptosis. There is enzymatic lysosomal activation with necrosis. Necrosis, there's going to be inflammatory responses. And with apoptosis, there's phagocytosis of those fragments. And it's nice and orderly. This is just kind of gross. Activity, and that's it.